Thank you for joining us today. Now we return to our speaker for our traditional City Club question and answer period. We welcome questions from everyone, including guests. Holding the microphones today are Director of Development, Jessica Allen, and Assistant Director of Development, Marcella Brown. Now, our first question, please.
Hi, Dr. Emmanuel. You call your plan the Guaranteed Health Care Access Plan, but I wonder whether you may be confusing insurance coverage with access. According to your statistics this morning at the grand rounds at UH, Massachusetts only covered an additional 1/3 of their uninsured when they changed their plan. Yet they developed a backlog of access to primary care physicians that was an incredible number of months long. Given that our ratio of specialists to primary care physicians in this country is the inverse of that found in most industrialized countries, and that they don't have the same kind of access problems that we have, how would your plan, or would your plan have any method of addressing the imbalance of the lack of primary care physicians compared to the number of specialists?
That's a great question. So we have in the United States only about 20 to 25% of physicians are classified as primary care specialists. And as you correctly point out, most universal coverage, countries that have universal coverage have 70% or so of their physicians are primary care doctors. That is not a ratio that you can change overnight. It requires medical education, requires training. On the other hand, our plan there'd be a huge incentive for the insurance companies and others to begin paying primary care doctors a lot more and to change the fundamental dynamic of why people are going into specialties, especially lucrative interventional specialties. It's really all about financial incentives at that level, and it seems to me the fundamental change will only happen when we change the financial incentives facing doctors. If you come out of medical school with $200,000 in debt and you're looking at a primary care position that doesn't pay enough to pay off that debt, obviously your choices are skewed. So a major factor is going to be how the insurance companies and health plans change how they reimburse doctors, and I think you'll see a dramatic change under our plan. That's the first point. The second point is, in many countries, healthy people don't actually see a doctor. So, for example, if you go to Sweden, as I understand it, kids see a doctor right after they're born, and then, assuming they're healthy and nothing really happens, they don't see a pediatrician. They end up seeing nurse practitioners for a long stretch of that time. So there's lots of creative ways we could begin addressing this problem. In addition, I think we're going to have to clearly rethink how we deliver care. More collaboration, more use of nurses and other auxiliary healthcare personnel in the transition till we get more primary care doctors.
Dr. Emanuel, I think your plan is the best that I've heard.
Well, thank you very much.
And I hope it's enacted soon. My one question is, how do we get rid of and or condemn some of the fads in Washington that might prolong or prevent this?
So that goes even beyond my 4 points about political feasibility. So let me say a word about strategy. Clearly, healthcare reform on the scale that I'm talking about is not like going over and touching a light button and suddenly we'll have a changed system. Although I would note, parenthetically, if you look at history, we instituted Social Security in 1 year. We instituted Medicare and Medicaid in 1 year. But I don't think that's actually necessarily a good way to do it. So there are some intermediate steps we can do now in preparation, laying what I call the foundation building blocks for comprehensive change. And I'll give you a few. On the financing side, one of the things I would suggest that we do is have every state institute an insurance exchange like they have in Massachusetts that would be open to people who self-insure, to small businesses, and as I'll mention in a second, get some of the uninsured in there. require insurance companies to provide a package at a set amount, and to guarantee issue to people who want to pay the price. Second, the tax treatment for employer-based insurance should be limited. Now, President Bush, some of you may remember, I think 2 years ago, proposed to limit the tax treatment for employer insurance, but didn't link it with anything. And I don't think you can simply limit and take away that benefit without linking it to something important. So my third point is I would link that limit with providing coverage to the uninsured, beginning with uninsured children, the 9 million uninsured children and their families, and put them into the insurance exchanges. So the three plans I have for changing the finance system is these insurance exchanges, limited tax deductibility for employer-based coverage, and use that saved money to cover children and the uninsured, boosting and strengthening those insurance exchanges. On the delivery side, we need to create that Institute for Technology and Outcome Assessment. Actually, right now, Congress is considering legislation on that, and if you're at all politically active, I would urge you to have your congressmen and senators vote for that, because that is pivotal. Second, we need some other legal reforms to allow more coordination and integration of care. And third, we need to have Medicare begin a lot of experimentation with paying doctors and hospitals and other healthcare providers in new ways that encourage coordinated care. Let me say a word about that. I don't know the best way to pay doctors and hospitals. I'm not that smart. I do know the worst way. That's what we're doing now. Because we encourage fragmentation, we encourage doctors to do more rather than to do better and to provide high quality care. There's no measure for quality in the system, but we don't know what to change to. So we need experiments, innovation in delivering better care. And we need to foster that and encourage that. And to do that, Medicare needs to try out lots of different things to see what works, to measure quality of those experiments, and to push it along. So those would be my 6 steps. After those steps are in place for a few years, I think the transition to my plan becomes much more palatable, because you see insurance exchange working, you see our ability to get more uninsured, you see more cost-effective care in the delivery side, and so the transition is much smaller. So that would be my main answer to you. Don't try to swallow the whole thing at once, but have very concerted building blocks that build towards the goal. Is that helpful?
Dr. Emanuel, your plan, it strikes me as being very comprehensive on the delivery side, but less direct on cost-saving side. And I would like you to address the providing of incentives to those of us who are going to be participants in the system, particularly with respect to health information technology. How do you build incentives with respect to that? Because you want to collect the data that your system, your plan really depends upon. The second is, how do you incent wellness in this plan?
Great question. So let's first talk about the information system. Everyone believes, and almost every study done of health information system is that they're going to make a huge difference. And yet, uptake in the United States is the slowest of every developed country but one, Canada. That's because we have a lot of private practitioners who work in solo practice, and both the financial and other resources necessary for computerization are beyond their means. The payback on health information investment turns out, and this is not just in healthcare, but from almost every industry, is 10 to 15 years. And most small businesses don't make investments on that time scale. And the real payback will only happen when you really get 100% or 90% of the whole healthcare system on the electronic record. So you actually put electronic record in, you get your lab results, you get your radiological reports, you get your referrals. I believe the federal government's going to have to make investments, and actually I should have mentioned that the federal government's going to have to make a serious investment in that, and that's the only way we're going to catalyze it. My own personal proposal for that is we should tax all payments, 1%, put it in a pot that goes exclusively for making computerization electronic records available. So I don't think it's going to happen. I mean, I was trained as a chemist, and so we have a potential energy barrier problem. At the other end, everyone will get that, it'll be a better system. But to get over that potential energy barrier is going to require a catalyst, and that catalyst is the federal government.